Next, we have Dr. Brian Fraley. Brian was born in central Kentucky but was raised on a commercial cattle ranch in western Colorado. He started shoeing his own ranch horses at the age of 15, and that quickly morphed into a full-time business. He then received his DVM from Colorado State University, following an internship and employment with a large referral equine hospital. He established Fraley Equine Podiatry. He and his team have been providing podiatry care nationally and internationally since 2009.
Okay, I'd like to thank the CBA for inviting me, and thank you guys for attending. I'm tried not to have too much overlap with the rest of the panel, so I wanted to go into a few of the other problems that are often secondary to some of these conformational defects. I'm fortunate to be located at the Haggard Equine Medical Institute. I'm an affiliate there, and I'm blessed to have a great team of support around me. And a lot of these cases we all worked on together. Added a new team member this year. That's my little girl Adeline. She's a little over 5 months now, so that's been life-changing and reprioritizing for sure. But another passion of mine is foot care, and this is a very common problem secondary to some of the clubby feet that Dr. Morrison showed earlier. So very common problem. We see it a lot, and it's something we often ignore, but it can result in other problems, especially secondary infections from having all of this gravel. See my point? Sorry, my pointer there. So if you see all that debris up in the white line, and also there's a small toe crack that's full thickness right there. So I try not to ignore these things, and oftentimes we can help improve the clubby foot with the addition of a toe cap to things like this, but we're careful not to just cover it up. So we're careful to clean it really well, sometimes clean it, keep it in a dry foot pack, and come back in a week or so just to make sure we're not sealing up bacteria under the glue. So here we see, and Dr. Morrison showed a few of these. This is just a Kevlar type material, polyvectran. It's really wear resistant, and we placed it at the toe of the foot. I really like this. It's very subtle. We try not to keep it beyond the widest part of the foot for reasons that Bobby was mentioning. You know, we have a young growing foot. We want to minimize the contracture in that foot. So this is a nice way to protect the toe, keep the environment out, keep some of that class I sand out from around the waters, allow the health of that toe area to improve, and also the horse somewhat self-trims. So we're protecting the toe, they're somewhat self-trimming the heel area because it's wearing. Here's another look at little toe crack, full thickness with debris packed in there after just running a rasp over it. So that's very close to sensitive tissue and can result in a severe abscess. So we just things to keep an eye on, and things that the farrier are looking for every day as they're trimming on the farm, and things that we can look for too as managers. Here's a full thickness grass crack that they're classified as grass cracks because it originates from the ground and goes up versus a sand crack that originates from the hairline and goes down. So here's a full thickness grass crack that has allowed bacteria access to the sensitive structures. It's followed the path of least resistance, and we have an abscess popping out at the coronary band. So we try not to ignore things like that because even minor little abscesses, as you know, can turn into serious ones. But foals are very resilient. They can go badly quick, but they can also get better quick. So that's a big fun part of treating young horses is their remarkable ability to heal. This is a 8-month-old thoroughbred that had a minor looking defect, full thickness in the toe area, grass crack, that led to an abscess, unresponsive to treatment, to conservative treatment, poulticing, soaking, and antibiotics. We cultured this thing, took radiographs, found that this foal had a very large sequestrum off of the lateral portion of the coffin bone. So that sequestrum is circled there on the far left, and that's just a piece of bone that's isolated from its blood supply. and is acting like a splinter. So this is an infection that's not going to get better until we pluck that out. The scary part of this one is it's very close to the coffin joint. And in fact, when we tap the coffin joint, it was infected. So that raises the bar of problems, elevates this to a really very guarded outcome because it was so chronic in this case. But we went ahead and removed the sequestrum. It plucked right out because it was not attached to anything, fairly rotten, and then used a lot of supportive therapy, changed the systemic antibiotics based on the culture results, did regional limb perfusions, and foot soaks. The Whirlpool boots, they're great. I think every farm should have them. We were able to just constantly soak this thing once a day. Sometimes larval therapy we'll use in cases like these, but just other adjunctive therapies that can help. We were fortunate in this case to have a very good outcome. This foal's sound at the walk as of now, and we have a fairly good prognosis for athleticism because at the moment it looks like the joint surface is intact. I'm saying the prognosis is open, but it's a lot better than I thought it was going to be. And that was just about 60 days. Here's a favorite case of mine I like to throw up just because, again, it shows the remarkable ability of these cases to heal. This is a flexural deformity like Dr. Morrison showed earlier. So we have a horse that has a couple of things going on, contracture of the superficial and contracture of the deep. This horse had 2 surgeries. It actually had a superficial check ligament desmotomy and an inferior check ligament desmotomy. So in an effort to try to help this horse, and it did not respond to surgery. We had this, we were called to look at this. We've got this coffin joint that's essentially subluxating or almost dislocating, and the fetlock's fused in this position, seemingly fused in that position. So that slide was a little bit out of order, but the treatment on this foal, weanling, we went ahead and blocked the horse, broke down scar tissue physically, and then casted the horse to try to get things in a normal position. So the middle picture, the top middle picture shows we tried to get the phalanges in normal alignment and casted it, and then we used the Dynasplint, which some of you might be familiar with, to keep constant tension on the fetlock because we had this horse still knuckling against the top of the cast. So with just some time and attention, actually some acupuncture, we had a very good outcome, and this horse did go on to train. This was actually not a thoroughbred though. This was a standard bred horse, so pretty tough horse, but still pretty remarkable. Scott already touched on this, so I'm gonna breeze over this a little bit, but I totally agree with him in that we try to avoid the use of glue and extensions, much like Bobby said, until after that first week of life, except for, even in the really severe cases, try to give them time. We often see a lot of cases go badly from infections, often from those little minor heel bulb rubs. So oftentimes we'll wrap them lightly, try to get through that first week of life, and then move to shoes. So this was a horse that was given time, didn't come up, and then we applied shoes. Oftentimes it only takes a week and a little bit of controlled exercise. And again, the worst thing we can do is bandage these things. They just get weaker, and then often the tendency is to lock them in a stall as well. So that doesn't help either. So we need controlled exercise and some support to keep them from getting these rubs. Very severe case, which Scott showed some great ones. They're a lot of fun to treat because they often do come up. We're careful. Things I would change about this picture: I've got glue beyond the widest part of the foot, and here later you see how that we've contracted this foot. We see the heels are kind of pinched, and I'm just going to outline that with my arrow. Not cooperating, but you can see the pinched heels from the glue. So, and that's a downside of locking in a young growing foot. So here in the other picture, as I learned from my mistakes there, we're trying to keep glue forward to the widest part of the foot. I've got the frog loaded with impression material, and then we've tried to let those heels move a little bit. Scott mentioned mechanical founder in some of these cases, and we've got a little seroma at the toe just from trying to load that toe too much. We're actually anchoring all that horse's weight on the dorsal lamina right there. So we're having to deal with that secondary complication. And then here we see the horse, did come up. We're barefoot, fairly good conformation. These are readily available. 2 different extensions I show here. We've got the Ibex baby cuff, which I like to have in the truck because you can do multiple things with it. It has a toe extension, a heel extension, and a medial lateral extension. And then the Dowrick foal extensions. So some farms will bandage things like these on. We see complications from that. Here's a horse that Scott showed a slide just like this. That horse got a bandage shifted, and we got one mechanical founder as well as some pressure necrosis, I think, from the bandage. So here we have a horse actually sloughing its hoof capsule, and we've got the coffin bone trying to penetrate on the horse on the left. We're really careful, try not to torque on these immature feet too much with a toe extension. This is another case where premature horse, very immature foot, toe extension actually ripped the hoof capsule off, but this is just an illustration. Really, it wasn't really the toe extension's fault. The horse had salmonella and thrombosed the blood flow to its distal limbs, and then the toe cap just helped the foot come off. So just illustrates we really need to be careful with being aggressive with toe extensions. Here's a foal that was stepped on by the mare. We had an open articular fracture. Dr. Rogerson actually lavaged some gravel up near the coffin joint out of this foal, wired it together, and then we worked on the foal the next morning and used larval therapy, put a piece of metal aluminum bracket across the crack with Equilox and a treatment plate, and this foal had a very good outcome. Here you see one thing we have to manage with foals in a bandage is we induce some laxity in this foal just from bandaging it so much. So here you see on the far upper right-hand picture a heel extension to help kind of mitigate some of that bandage laxity that we had caused. But just another illustration of how well these foals can heal if we give them a chance. But with that, that's all I have for you. Thank you for your attention.
Our next speaker is Dr. Dwayne Rogerson. Dr. Rogerson is originally from Prince Edward Island, Canada, and completed his Doctor of Veterinary Medicine at Atlantic Veterinary College. He completed a surgical internship with Haggard Equine Medical Institute prior to his residency and master's program at Auburn University. After that, he joined the University of Missouri as a clinical instructor in equine surgery. He later moved to the University of Florida Large Animal Hospital, where he was a clinical lecturer and assistant professor. And then he joined the Haggard as an equine surgeon in 2002 and is a member of the practice. Dr. Rogerson.
Thank you. I'd like to thank the CBA for having me. Dr. Spirito was supposed to do this, but he's actually on a plane right now going to Costa Rica. So we can all hope he doesn't get sunburned. But I'm lucky to work with Dr. Spirito, and I got the opportunity to work with Dr. Thorpe, Dr. Hunt. So I'm very lucky that I've worked with people that have a ton of experience, and that's what veterinary medicine is. That's what I tell our interns. It's experience. You can read all the books you want, but it's experience. And I don't have the experience that Dr. Spirito has, or Dr. Thorpe, or Dr. Hunt. It's a time thing. You just have to be patient. So, I'm lucky to learn from my own mistakes. I also get to see how their cases turn out. So I'm going to give you a perspective on angular limb deformities, kind of, from a surgeon's standpoint. If you look at angular limb deformities, if you look at the definition, it's just a deviation in the frontal plane. And that just means you're looking at the foal in the front. What way does that lower leg go? Does it go to the outside or does it go to the inside? And you'll hear me say lateral is to the outside, medial is to the inside. So if we look at this slide here, we have a valgus deformity. If you want to, classify it's a carpal valgus deformity, a valgus deformity at the level of the knees. So the bottom of the leg is going laterally. If we look at the opposite, it's a varus deformity, bow-legged. So the first was a knock-kneed appearance, the second is a bow-legged appearance. And obviously this is a mare, and is that coming up too dark? Can you see it? It's a bow-legged appearance in the mare. They're commonly observed. The joints involved, typically we look at, are the fetlock, carpus, and the hocks. And there's variations as far as single, multiple deviations, and they can be mild to severe. So what I'm going to talk about is fetlock deformities. I'm going to focus on the fetlock, and we'll have an odd slide of a carpus, but we're primarily going to look at the fetlocks. There's two types. There's congenital, which is easy, they're born with it. And then there's acquired, they get it, they develop it. If we look at congenital deviations, they're present at birth. It's soft tissue laxity. They haven't had a chance to stand up. They haven't had a chance to strengthen things up. Uterine malposition, how they lay in that uterus. Left hind leg varus deformity, where it toes in the left hind leg, is very commonly observed. And that goes to show that these foals seem to lay on their left side. But we see that very commonly. An odd time you'll see the right, but it's mostly the left hind. Growth discrepancies at the growth plate, or the physis, and we'll get into that when we get into the acquired. When you look at the hock and the carpus, we have those small bones in those joints that haven't really ossified yet, haven't really calcified, so they're still cartilage, so they're soft. So when the horse stands, the legs kind of go out. And then you also have some oddball curvatures within the long portion of the bone, which is not very common, but we do see it. In this particular slide, we have a congenital deviation. We have a carpal valgus, as well as the so-called windswept foal, where we have a valgus deviation on one leg and we have a varus deviation on the other leg. This is one of these left hind fetlock varus deviations. It should work. And you can see the left hind, it's born with it. It's toeing in on the left hind. So we do see that commonly. So, look at the front legs, but also look at the hind legs too. I just pointed out with my foot. Fetlock deformities, most are these, when they're congenital, we treat them conservatively. Stall rest, exercise restriction. Very rarely do we jump in and do surgery, and very rarely I do. I try to give them a chance to get better. I try to give them a chance to see how these things are improving, if they are or not. If it doesn't seem to be improving, then we have plan B, the option to fix it surgically. You can go with regular, there's corrective trimming, glue on shoes, splinting, but the key is to look at these foals again. Stay on top of them every 2 to 3 weeks, especially for fetlocks. If we decide to do surgery on these, I usually try to wait until we're about 3 to 4 weeks of age, 6 weeks. I've really tried to give it a chance to improve on its own. If I have to do surgery, then I jump in and use the single screw technique. But the decision to jump in is usually based on a lack of improvement. One limb is obviously really deviated quite a ways, from the other leg, so you got to try to make them match. And said we typically jump in 3 to 4 weeks, even 6 weeks, depending on how, the foal looks. That's congenital. Acquired is the most common. And the big thing with acquired, everybody thinks, it doesn't ask this question. I try to tell my interns and the residents that come through, ask this question. Why do things occur? Why? It just doesn't occur. It has to be a reason this is occurring. So you have to answer that question. Look at the foal and figure out what influenced this foal to make this foal become crooked. All right, so ask the question why. It's usually due to discrepancy in the growth plate, or growth at the level of the growth plate of the physis. There's a difference in growth at that physis. All right, so we get fasciitis, epiphysitis. All right, we're going to use the term fasciitis through this talk, but I may say epiphysitis, but I'm meaning the same thing. It's usually inflammation at that growth plate. Something's affected that growth plate that affects the growth on that growth plate. It can be septic, where it's an infection, but generally it's not. It's usually due to some sort of force on that growth plate. You have to ask the question, what is that force? It can be trauma due to a fracture through there, but generally not. And it can be clinical, where it's obvious. You just look at that leg, you palpate that leg, it's hot, it's sore. But a lot of times, epiphysitis is going on, you don't even notice it. And when you do see that foal crooked, you're sometimes behind the 8 ball. So what's fasciitis? Okay. We're looking at the fetlock. This talk is on the fetlock, so everybody knows where the fetlock's where it's at, where we're looking. But if you look at the growth plate here, you have what we call the distal growth plate of the cannon bone, or the metacarpus or metatarsus. So we can see the two growth plates at the level of the physis. So we have the distal cannon bone, and we have what we call proximal P1. The top of the pastern bone also has a physis there. We don't really focus on the pastern physis. We're typically focused on that distal cannon bone. When you look at the carpus, there's really only one physis here, and this is a good example of the radiographic signs of fasciitis, epiphysitis, where we have this open physis and evidence of bone proliferation at that distal physis of the radius. So the thing you have to first look at is the center of gravity of that limb. Everybody thinks it's straight down that limb. It's not. It's shifted a bit to the inside, bit to the medial side. Most common site for epiphysitis is usually the medial side of the carpus and the fetlock. If you had to ask a surgeon, where do you see it mostly? That's where we see it. That's because that center of gravity is shifted just to the medial, just to the inside of it. You also see epiphysitis or fasciitis on the lateral aspect of the carpus or the hock. So what we're going to do, we're going to divide this growth plate into two. We're going to look at the inside of it, and we're going to look at the outside of it. And to have normal growth, you need to have equal growth, that growth potential, that physis, on each side. If you get a discrepancy in that growth potential, the angle of that leg's going to change. So we have the lines drawn through the radiograph here, looking at the physis. We're going to cut this physis in half and try to look at this radiograph in 3D. Radiographs are two-dimensional, but you have to think three-dimensional. So here's the growth plate, and we're going to cut it in half on both the radiograph and this kind of illustration here. If we got equal growth on both the inside and the outside of that physis, that leg's going to stay in alignment. If we get one side affected because of epiphysitis, and that growth potential slowed down, one side's growing faster than the other. So you're going to get a deviation on this right illustration here. How do we stop that? Technique is the single screw. We come in, we try to stop the growth, not really stop it, slow it down on the side that's growing fast, so that we get it to slow down, and if we do the screw at early enough, maybe the inside has time to potentially grow again and push that leg back out. But on the fetlock, sometimes, and I'm going to show you this scenario, we're basically trying to hold it from getting worse instead of correcting it. But we'll get to that. So the epiphysitis or fasciitis can vary in how it affects that growth plate. It's not going to be the same every time. Some are going to be more affected than others. The more it's affected, the greater the deviation is going to be. So if you look here, we have epiphysitis down here at this distal cannon bone here, and say it's affected 70% of its potential now, not 100%, it's not 100. But in severe ones, oops, went too far, you'll start to see them toe in. So the greater it is, they can toe in very fast. So what are the factors that cause this fasciitis? This is important. Genetics does play a role. Horses that have the offset knee appearance are putting more load on the inside of that bone, on the medial side. So they're more at risk to getting fasciitis on the medial side of that fetlock. Bone structure. And I'll talk about this in a minute. Fine bone horses with a heavy body style are more prone to epiphysitis. Horses that have kind of a base narrow or base wide appearance affect this, they put different loads on those growth plates and they potentially get fasciitis. So genetics does play a role. But the external factors are very important. So if you're raising horses, this is where you got to look at these horses. Most of the time you don't get it, but try to pick out which individuals are going to be at risk to epiphysitis. Body weight. These are growing animals. Body weight is important. In Lexington, Kentucky, we have green grass. You watch these foals blossom when the green grass comes out. You watch the yearlings just develop when this green grass comes out. That weight can affect the growth plates. So the horse's body weight is transferred down the leg, so that those legs have to support that load. And you're going to get that applied to the growth plate of the carpus as well as at the fetlock. Obviously, this horse is at risk. There's going to be greater load coming down on those growth plates, all right? So that is picking out which ones seem to be the better keepers. They just, they're a bit more well-fed in a sense. Which ones to watch. So in foals, it gets tricky. How do you decrease their body weight? You can try to decrease that energy and protein, but they're nursing. Some of them, as they start to get into the mother's feed bucket, raise it. Try to maybe decrease hers a little bit. Or if you have them on a nurse mare, some of these draft-type nurse mares, they're just nursing so much. They're just getting so big. Wean them a little bit earlier. That extra weight can be a nightmare for you. Exercise. Everybody wants to turn them out. Everybody loves when these foals are out there running, the mare's chasing it, but that's generally not the case. A lot of times these foals are trying to keep up to the mares. You know which one's going to go faster. And they have to work pretty hard sometimes. They're running, they're pounding on those legs, they're really just working it. And that trauma can affect the growth. Once you wean them, they're out there playing, doing the same thing. So it just doesn't stop, it keeps going. And then when they're yearlings, they're still out there racing. Who's the fastest? And it's up to you to pick out which one maybe not the fastest, but likes to eat. Maybe you back off of that one. Maybe minimize his exercise. Exercise and increase weight. It's not hard. Which horse has more load on his growth plates? All right, so watch them. This is important in fillies. You see this commonly. Fillies are just like people, typically finer boned than the male. If you get a filly that has that finer bone structure and has that beautiful body, and at 2 months of age, they're bringing it out. The first one they bring out to all their shows is their filly, and it's just gorgeous. Then you see it go at, like 90 days. It's got epiphysitis. The legs are changing. You got to watch those fillies. Hard ground. We see it in this, summer. Once the ground gets hard, they're out pounding on that ground. The ground doesn't absorb the force as well as it did. So when the ground gets hard, you'll see more of this epiphysitis. They're out there running, pounding on that ground. So the forces are coming down the leg as well as going up the leg. Lameness. This sometimes can be very subtle. Both legs should bear equal amount of that horse's weight. If you get a problem where one leg doesn't, is lame and it's, in a sense, balancing itself 60-40 instead of 50-50, one leg's bearing more of that load. And that sound leg is going to get epiphysitis. So when we have a lameness, I'm always watching that other leg because it can get epiphysitis. This can occur from a foot abscess. Horse gets a foot abscess. Boom. 3 weeks later, you got epiphysitis. Lacerations. Simple laceration. It bothers the horse enough where it's now balancing itself 60-40 instead of 50-50. Transphyseal screw. I've made this mistake before where one leg looks okay, the one leg looks like it's tracking straight. I put a screw in the left front ankle, the right front ankle goes. Because that screw hurt the foal enough where he bared a little bit more weight on that leg, or the opposite leg, and got epiphysitis. So you got to watch him close. You got to recheck him. And I've had that happen numerous times where I've kicked myself in the rear end. Another common thing where I get called out to farms, just an example, it was a rotation deformity, where they call you out to look at the leg that's rotated. So the horse is standing with one leg rotated out. But if you do this as a person, which leg's bearing more weight? This leg. So this is the leg you want to watch. As a surgeon, we can't fix rotation. So you watch that other leg, because that leg can toe in. So ask yourself the question, Why did I get epiphysitis? A lot of times, most of the time, you'll figure out why you got it. So how do we look at these foals? We'll finish up here real quick, just watching them at rest, standing there. We watch them walk as well. For ataxia, we're looking at them for that as well. Radiographs, it's in book. Every book you open, it says radiograph the joint to see where the so-called pivot line is. We don't do that. We watch them walk, and we watch them at rest. When I'm doing this at the farm, I have my iPhone, or if you're, BlackBerry or whatever, Android. There's a number of apps on these phones where I call it in, record it, I record my findings, and I send it to our secretary. She types it up, and we keep a record, because you want to be honest to yourself the next time you look at that horse, what you saw the last time. We're looking at what joint is affected, the severity of it. We're looking at evidence of epiphysitis. Is there any evidence of epiphysitis there? How bad is it? Is there any correction on that hoof wall? And then recheck in 2 to 3 weeks. So if you look at this foal, this photograph here, you can see the epiphysitis at the level of the fetlock and at the level of proximal P1. So we have it at the distal cannon bone and what we say top of P1, proximal P1. The next photograph is a little bit more obvious. And we also have this full toeing in. The next case shows epiphysitis, both on distal cannon bone and P1, but also the correction that's on that foot. Make note of it. How much correction is there? So quick surgical correction. I'm not going to show you how to put a screw in. If you ever want to come in and see surgery, you're welcome to come in. This is a very easy technique. We do it for mild, moderate, severe deviations. The normal conformation is a horse that's slightly valgus and straight through the fetlocks or slightly toed out. That's what everybody wants. So we try as surgeons to give them that when we work on the fetlocks. If you fix these, as mentioned earlier, it does potentially improve their longevity as a racehorse, especially the more moderate to severe ones. It does, help the lower joints. This decision to perform surgery, why? Why perform surgery? Severity, it's an obvious decision. You look at the foal, there it is. History of previous foals. As a vet, I want to listen to you. If you tell me the last 2 foals were crooked, I have to listen to you. So listen to the owner, listen to the farm manager. Conformation of the mare. When you're there watching the foal, look at the mare. And sometimes we know what the stallion looks like, but sometimes we don't. The future sale date, time it on, when's that horse going to the sale? Degree of epiphysitis. Tendencies. You keep seeing it on your notes. Every 2 weeks, you keep seeing it. The value of the animal. The horse is really valuable. You're more likely to do something. And clients' request. Sometimes clients, they just want it. They love the single screw. They want it, and you do it. Generally for fetlocks, when I'm doing them, it's around 8 to 14 weeks. That's when I like to jump in. If you look at this graph real quick, congenital, you're jumping in at around 3 to 5 weeks, say. But if you look at when you jump in on the other joints, fetlocks, you're generally jumping in at 2 to 3 months of age. Hocks, you got to wait, let them mature a bit. And the carpus, you can jump in early on and even a little bit longer. The transphyseal screw, and I'm going to give credit where it's due, Dr. Paul Thorpe, he's an innovator and a legend. He came up with this technique. He started it on hocks to begin with, then he adapted it to carpus, and then to the fetlock. So he deserves credit. This is his idea. It's a great technique for fetlocks. The bump is really, really small if all goes well, but it is a surgical procedure. Anytime you do surgery, you have risk. It's not a guarantee. It's easy and efficient. You can remove these standing at the farm, but you got to put them under anesthesia to put them in, especially for fetlocks. And the cost range, depending on the clinic, we're about, it ranges from $1,000, $1,500, and that's everything from going in to coming out. These are the 2 scenarios. The first scenario is where you're putting these screws in around 2 months of age, 6 to 8 weeks of age. And this is where you potentially improve the conformation. You can get these foals to actually improve. But then you get the other scenario, the second scenario, where these foals, you're losing them. You're losing them at 10 to 12 weeks. They're just going because of epiphysitis. Your goal is to keep them from getting worse. And that single screw, if you put it in there, can hold those folds. You're not going to improve them, but you'll keep them there. And you got to look at it. If I didn't do it, it would be a lot worse. The single screw, basically you drill a hole. You can use 4-5 screws or 3-5, generally using the bigger screws. Post-op antibiotics, bandages for 10 to 14 days, and implant removal once the deviations are corrected or at about 4 months of age. Or in some cases you can wait until you do your surveys and take them out as yearlings. And just go through some complications. Anytime you do surgery, you have risks, no matter who does it. Pressure sores, you've got to be careful. You don't want to bandage too long, because when you put those screws in, all you have is the screw covered by skin. So you put the bandage on too tight, it'll rub through the skin. So that's why I only bandage for a short period of time, because sometimes the bandage bites you in the rear end. Bone proliferation. When you put that screw in, you can get bone proliferation where that screw was. And this is a tough one, because it can be the greatest surgery. I mean, it just went slick as snot, and it just gets this ugly bone reaction. You can't predict it. Implant removal, it can be hard. That's where in surgery we use the radiographs as well as ultrasound to help us find that screw. Surgery site infection, common. It can happen. It can happen as the sutures break down. Knock on wood, it doesn't really happen immediately after surgery, but it can happen. And then you got to treat them with antibiotics and try to minimize the flare, and they can go bad on you. Overcorrection. This photograph is an example of a staple, when we used to use staples for fetlocks. So it's not a single screw, because you're probably looking at me going, oh my God, he ruined that horse. But that was a staple. And that is a horse I worked on. And that's the bump you got with a staple. But you can see how it overcorrected. Not as common on ankles as it is knees, but it can happen. Implant failure. This is a radiograph of a knee where the screw broke. Not really a problem with the fetlock. So just to conclude, fetlock varus deformities can be improved surgically. All right, it's an option. Not every foal needs to have it. Sometimes I say the best decision a surgeon makes is not to do surgery. So not every foal, don't get in a rush to do them, because bad things happen to good horses. So sure enough, it'll be your best horse, and it's the one that dies under anesthesia. It's easy to do, it's very efficient. It's important to understand why these deviations occur, and that's what I wanted to stress. Why are they occurring? And therefore, you can look at these risk factors and try to prevent it. And just remember the complications. You have anesthesia as well as the complications from the surgery. So, thank you.
Thank you. Okay, our final panel member is Dr. Wesley Sutter. Wes Sutter was born in Lander, Wyoming. He received his Bachelor of Science in Biochemistry from Colorado State University in 1997. He then completed his doctorate in veterinary medicine from Colorado State in 2000. Following veterinary school, he completed a one-year rotating equine surgery and medical internship at Rood and Riddle here in Lexington. He then completed a surgery residency at Ohio State and was later an assistant professor there. He then, after 5 years, had at the Ocala Equine Hospital. He moved back to Lexington to found Lexington Equine Surgery and Sports Medicine here in Kentucky 3 years ago. Dr. Wes Sutter.
Thank you. It's a pleasure to be here, and I want to thank the CBA for inviting me. Dr. Rogerson did a great job, and hopefully I'm not going to repeat too much of what he said, but there will be some overlap. I'm going to try to talk specifically about the surgical correction of carpal angular limb deformities. If my, there we go. So the first question, I think, whenever you're talking about surgery, is what can you actually correct? And it's been talked about a little bit here, but I want to emphasize the point that there are only so many things you can do surgically. And basically what we're looking at with the knee is we're either going to be able to push the knee in or push the knee out in one plane. We're not going to be able to correct many of the rotational deformities that we would like to, but some of the rotation, and I'll talk about the deformities a little bit, some of these valgus and varus deformities have some rotation from the knee down that will improve with surgery. It's not always predictable, but you will get some improvement. And then, of course, sometimes some of the deformities you're not actually correcting, as in the offset knee, the deformity directly, but you're improving the mechanics of the way the horse goes. So you've already seen the varus and valgus, and I'll go through that a little bit but what I want to kind of focus on a little bit is evaluation, and I think this is one of the things for me that is very important. There can be a lot of factors that impede your ability to evaluate these horses and watch them walk. Let's see if this video works. But I like to, if possible, have an area that's quiet, where you can see the horse walking forward. It's of course flat, and if you can see them without correction, that helps a lot as a surgeon. Because one of the more disappointing things is that you correct them with the correction, and when the correction comes off, well, you didn't correct them enough. So, or at least a relationship and with a farrier and a history of what's going on helps dramatically in success with these. So we talked about varus, valgus, or Dr. Rogerson did, carpal varus. Of course, these are going to be the horses that are bow-legged. Frequently, they'll turn in just a little bit. Conservatively, these are a little bit more difficult to manage than the carpal valgus ones, and more of these horses will end up getting surgery. It usually worsens as the foal gets older, becomes a yearling, and the chest widens. And of course, this is a highly undesirable trait. Most of the injuries and the stresses are on the inside of the leg. I just want to talk a little bit about offset knees. There's a couple different ways of describing them, but basically you have two deformities in offset knees, and I don't know why, but we do see a lot more, it seems like, offset knees now than when I started my career. But the problem with offset knees is at the top of you have a deformity at the top of the knee at the growth plate where the knee actually goes in, and then you have a second deformity at the bottom of the knee which makes the cannon bone come in. So functionally, when these horses walk and the way they go, they're varus, but the knee is already going in. There's little that we can do to correct this bench or offset knee appearance, but if they walk and roll the knee outward like you see with many of the bow-legged horses, you can push the knee in a little bit further. So you can improve these horses that are rolling the knee significantly. Let's see if I can get this. I was afraid to put too many videos in, but I think here you can see, and a lot of times walking away, it's easier for me to evaluate knees, especially when they're rolling laterally. But here's one with hopefully you can see a pretty marked offset knee and lateral roll from varus deformity. And some of these horses you're going to be able to help out by pushing the knee in further and straightening the cannon bone up. You have to be careful, at least in my experience. If they're walking well over these knees, you're not going to correct or improve that offset appearance of the knee. So the screw in these horses is purely, at least in my mind, to improve the way they walk and improve their mechanics. It doesn't improve the outward visual appearance. Carpal valgus deformities, this would be the opposite. These are the knock knees. Foals, a lot of these improve with time. You like to see a little bit of carpal valgus in the young foals, toeing out a little bit, because as they grow and their chest widens, the legs are going to straighten out. There's also some evidence, although there can be some argument, that it is protective for the racehorse to have a mild valgus deformity, and this again is getting back to most of the pressure and the stresses are on the inside of the leg. So when they're slightly knock-kneed, you're redistributing more stress on the outside of the leg. But these can be, if they're severe or will affect sale, they can be corrected. So I'll talk a little bit, and Dwayne again did a good job about the treatment and the timing when we like to do surgery on knees. And I think it's important that you know the functional closure times, and this is variable between individuals and breeds, but once you start to get at 4 to 5 months for fetlocks and you have much more time with knees, you don't have as much room to correct a deformity with surgery. Often I'll be asked to, well, let's take an x-ray and see if the growth plate's still open. It's an older foal or older yearling. And the one thing to keep in mind is as you approach the ends of these timelines, the growth plate may still be open on x-rays, but it doesn't necessarily mean there's enough functional growth there that if you do surgery, that you're going to be able to correct the deformity. So staying on top of these, I think, is important, and I think everyone has kind of stressed that today. Periosteal elevation and transection without opening up too big of a can of worms is controversial, I think, still among surgeons, whether or not it works. I don't do very many periosteal strips, but it's something that has been done in the past. There are some advantages, and that the main advantage is there's very few complications. It's inexpensive, it can be done in the field, but the biggest disadvantage is the efficacy, and it's questionable. And if you are on a timeline and you're waiting for the periosteal strip to work, you may miss your window to do something like a transphysial screw or transphysial bridging procedure. Transphysial bridging procedures are done to inhibit growth, whereas periosteal stripping is done to increase growth. So you do them on the opposite side depending on the deformity. So the disadvantages of doing surgery, obviously, is they have to go to a hospital. It's more expensive. On all of these, the implants have to be removed. You can have surgical blemishes and infection. There are two variations that are used currently. I don't know anyone still using staples in the knees, but there may be someone, and that's screws and wire and a transphysial screw. And I think you're going to hear a lot of different opinions, and I'm probably somewhere in the middle, which technique's better. Certainly for fetlocks and hocks, I wouldn't want to live life without the transphysial screw and go back to screws and wires. It's revolutionized the way we treat these angular limb deformities, and it's definitely the technique of choice. The advantages of the single screw technique, and Dr. Rogerson talked about it, and they've been doing them. They were the first to do them, and they've been doing them for years, so they have a lot of experience. The advantages are that it's a very quick correction. Basically, once you put the screw in, the growth plate is loaded, and they're going to work quicker than maybe a screw and wire, which is going to take some time to tighten. Usually you have very good cosmetics, at least relative to putting two screws and a wire in, and a lot of times you can remove them fairly easy standing. They can be difficult, but in a lot of them you can remove them standing. The disadvantages of the transphysial screw, particularly in the knee where you have a long period of time for closure, is that you can have some, and this is also debatable, but you can have functional slowing or stopping of the growth plate, whether it's metaphyseal collapse, whether it's disruption of the blood supply. I don't think anyone really knows, but you can certainly have some issues with overcorrection. And then it's reported that you have a higher incidence of epiphysitis after the screw comes out with the transphysial screw. And again, there's some theories on that, but it's not completely known. So screws and wire would be the other technique. The advantage of that is you're not going to go through the growth plate. Potentially you're going to have less epiphysitis. The disadvantage of a screw and wire is it's going to take longer. You're going to have to wait for this wire to tighten. And it depends a little bit how you put it in, but if you put the wire in and it's got a little bit of a kink in it, it could take quite a while to tighten. Usually they're 2 to 3 weeks behind a transphysial screw. Because you have more incisions, more metal, you typically can have a bigger blemish on these horses than you would with a single screw. I definitely, as I alluded to before, think this is a really bad idea to do in a hock or a fetlock. They cosmetically do not usually turn out well. And the added complication over a transphysial screw is this wire can break or slip off the screw head. And that can become problematic, particularly if you're waiting, wondering why it's not correcting. Oh, maybe it's just growing slow, and then pretty soon you're 60, 90 days and you take an x-ray. Well, the wire slipped. And then so you're getting closer and closer to the time when you need this horse to be ready. So if you have screws and wire in and they're not moving, you need to take a look. So this is just my general preference. Again, there's a lot of debate, and maybe we'll get into some of that in the panel, but for knees, I generally, and we're talking mild deformities, I like to manage these conservatively for as long as I can, usually till May or June, or at least until the yearling's a year of age. One of the problems if you correct these earlier is you may lose the correction, and it's certainly a mistake that I made early in my career is correcting some of these horses in January and February, and they look great in March and April, and then they get a little bit of epiphysitis, and then you're talking about doing another surgery, which doesn't make anybody happy. And many of the valgus deformities, if treated conservatively, will correct. Transphysial screw, I prefer to do these if we can do them in May over the screw and wire, but for the moderate and severe deformities that need to be addressed earlier, I usually do a screw and wire. So just talk a little bit about complications. I think, and as Dr. Rogerson alluded to, there are a few complications that come with this surgery, and probably more than any of us surgeons would like, and we all get them, and it's always a frustrating thing. But infection is one of those things that, and I don't know the answer to this. I have some theories, but the infection rate that we get with screws and wires, transphysial screws, a little higher than we would like. It's reported at 5 to 6%. There's no difference, at least in the study that was done. Comparing the two techniques, between the two techniques, whether you have a transphysial screw or screw and wire. To me, you kind of have infections in three categories. One, the superficial infections. These are the ones where they just maybe get a little bit of drainage and reddening around the incision. A lot of times this happens when you pull the sutures. I'm a huge proponent of scrubbing sutures before they come out, and I think a lot of surgeons would agree with me that it's really frustrating when the leg blows up a day after the sutures were pulled, and a lot of times that's because the sutures were dirty when they were cut and pulled through the skin. They inoculated it, and it's still your baby as the surgeon, but you would like those sutures to be removed. So usually, most of these superficial infections are surgery site contamination after surgery. And I think bandaging these things is very, very important. I've been informed and I've seen them put bandages on. The Telfa's laying on the straw, and the bandages laying on the straw. You need to be very clean when you're putting these on, because if the superficial infection doesn't respond well to antibiotics, you run the risk of it involving the implant. Once the infection involves the implant, it's much more serious, particularly if that implant's going across the growth plate. You can get a septic growth plate. Epiphysitis is a problem that we definitely see in these, I think, more than fetlocks, and most of it occurs after you remove the implant, and it can occur 2 to 5 months after. If you look at the study that compared the two techniques, it was much more likely with the single screw than with the screws and wire, and that's why you will see some people using the screw and wire over the screw and knees. The exact mechanism, again, is not unknown. It's postulated that maybe the screw can damage the physeal blood supply, but I don't know if that's true. It certainly hasn't been proven. Under an overcorrection, you will see both of these if you're going to do these surgeries, and I think a lot of this can be avoided with good management. I think I prefer that after the implants come out that you should at least take a look at them every week, because if the leg is continuing to correct, you want to be able to address that as soon as possible because of some of the complications you can have. If there's correction on the foot, you got to be careful. You got to make sure. I would prefer there not to be any correction, at least until we figure out where we're going with the knee. As I said before, the earlier you correct these yearlings, the more time they have to drift back before they go to sale. Continued correction after the implant is removed, so if the knee's still moving, the metal's out, I think is a cause for concern. Some horses will just do that and they're perfectly fine, but early recognition of this, and if you are going to have a problem with the growth plate. So if you have a problem with the growth plate, where you put the implant in, it's going to continue to move in that direction and overcorrect. The earlier you can address that, I think the better chance you have of that not becoming a big problem. Here's just a couple of examples of horses that had single screws and were having a problem. This is a horse that's, and this is the growth plate here. We can see where the screw was in this site. The growth plate's completely closed. And this horse has, you can't tell by the x-rays, has overcorrected. So the only thing you can do at this stage is salvage and basically stop the growth by putting a screw on this side. You're not going to get any growth out of the side of the growth plate, so what you have as your deformity is still there. On the left side here is one that we've taken the screw out and it's continuing to correct. I'm not liking the way this growth plate is looking. You can still see the screw track is pretty recent. So it's one that if you put a screw over on this side, you have a chance of actually getting the leg where you want it. So early recognition, I think, is really important, and watching these horses even after you remove the implants. The other problems, of course, white hairs. Everyone asks about white hairs. Everyone hates white hairs. To me, white hairs, unless they're on the suture line, are a bandaging issue. And too tight of bandages that are on too long is usually the problem. There's other reasons why if you do enough of these, you'll have disappointing results. And this is all about having the conversation before you do surgery and what the expectation should be. But we're not going to be able to correct significant rotational deformities of the legs. I think the severe offset or bench knees, when you put a screw in it, yeah, you may improve the mechanics, but you're not going to improve the way that knee looks visually. So everybody needs to know that before you do surgery, not after, and they're very disappointed. And also the horses that you're correcting a deformity in the knee, but they also have a deformity in the fetlock that was missed or didn't correct when they were full. The classic example of one of these that can be disappointed is the horse that's got a little bit knock-kneed and the fetlock's pretty straight, and then when you correct the knee and you push it out there, they now really toe in, and that certainly happens. You have to look at the leg as an entire system before you do these surgeries. And that's all I have. Hopefully there wasn't too much overlap. And
Thank you all very much, and lunch is served in the Limestone Cafe, and we will reassemble at 1 o'clock. We've had a very good full morning. We have a full afternoon. Thank you, gentlemen, very much. Thank you. Okay, thank you. Our first presentation of the afternoon is from Dr. Scott Pierce. Dr. Pierce is a Missouri native and attended the University of Missouri College of Veterinary Medicine. He joined Rood and Riddle in 1985 as an ambulatory veterinarian, where he continues his current practice. Dr. Pierce has researched and presented numerous papers both internationally and domestically on a variety of topics, including upper airway examinations of yearlings and foals. He has served on the AAP's Sales Integrity Task Force and has chaired the AAP's Public Sales Forum. Currently, Dr. Pierce's practice consists of public and private thoroughbred sales, as well as providing veterinary services to numerous yearling farms in central Kentucky. Dr. Scott Pierce.
Hello. Oh, it works. Is that too loud? No, I don't have to speak very loud. There's been many a time where applause wouldn't happen at the sale. But anyway, we'll get started here. Let's see. The topic is obviously, most of you know a lot of this stuff, but we're going to go over it again and review it. And then I've got some stuff, some videos, et cetera, that I'd like to show you just to really describe and to show everyone why in the world, with the advent of these scope certs and everyone taking these scope certs, why in the world would you ever want to scope a yearling at public auction? So we'll go over, I've got some interesting videos that we'll look at there. But basically, just to review, one of the disadvantages of pre-sale endoscopy is it's such a brief exam, and we're up against the wall a little bit at the sales. You have a very limited time to evaluate an airway and and you're finding so many things now later on with the dynamic and the overground examinations. But it's a very important part of the purchase exam. And another disadvantage is on the resting horse, but it's a quick exam, anywhere from 30 seconds to 2 minutes. So it does have its advantages and disadvantages. And we're asked to evaluate the function on this very short, brief exam, evaluate the function and the anatomical characteristics of the airway, and to give our opinion on the future racing prognosis. Okay, just to give you kind of the basic anatomy here that most of you guys know. There's your arytenoids here and here. Your epiglottis is this tongue-like projection that sits on top of the soft palate. So below the epiglottis is the soft palate. Here's the pharynx. Here, there's the vocal folds, vocal cords. There's the pharynx. You see little bumps. That's lymphoid tissue. People call it pharyngitis, but it's really tissue like our tonsils. So just basically a basic anatomy review there. Okay, common terminology heard at sales. Some of it I don't like. The A throat, and you guys know all this story inside and out. The A throat, that is maybe not the best terminology in the world to use, because an A to one person's A is not the next person's A. So it's trying to get away from these and actually use these grading terminologies like 2As, 2Bs that most of you know. But the B throat, it's impossible to sell those. And I was just talking to Frank Taylor. Some of these B throats do fairly well, but it's almost impossible to sell those at the sale. Pharyngitis, you hear that a lot. That's a common finding. I don't get too bothered by pharyngitis unless it's affecting the functioning of the airway, because all young horses have pharyngitis. And you'll see if you do an endoscopy or a scope on an older horse at 3, 4, 5 years old, you don't see any of that lymphoid hyperplasia. So they grow through that period into where that's not even an issue. The pharyngitis basically, or the lymphoid hyperplasia, is not an issue. So like I said, we're trying to get away, or we as a practice are trying to get away from these subjective, and I know it can be somewhat problematic because you've got buyers that say, what in the hell's a 2A? Well, that you're trying to explain to them what a 2A is, which is an A throat, but it gets a little problematic because they're so used to these grades like we got in school, A, B, C, Ds, but I've never seen a C scope. Now that would be probably paralyzed, but C's aren't all bad. But, okay, most of you know this. This is a good quiz for interns and vet students. They don't get these. But what conditions are the buyers covered against, okay? And this was done, I was on this task force along with others and put these together. Laryngeal hemiplegia, which is a paralyzed arytenoid, or the arytenoid cannot fully and maximally abduct. Rostral displacement of the palatopharyngeal arch, that's one of those that the vet students never get. It's kind of a weird thing. Now we're seeing, probably we're going to have to readdress this rostral displacement scenario, because this is becoming one scenario of a kind of a syndrome that we're seeing called laryngeal dysplasia. We're seeing other things associated with it, and it's diagnosed by ultrasound. There's cartilaginous defects of the airway, and they'll never be racehorses because the cartilage is malformed. So rostral displacement of the palatopharyngeal arch is just one aspect of that. If you see a foal, for instance, I had one in Saratoga this year, a foal that was paralyzed on its right side. I didn't scan it or have it scanned, but I know that was probably a laryngeal dysplasia because you rarely see that in foals. Epiglottic entrapment, that's the one where the epiglottis, we have pictures of all these. Permanent displacement of the soft palate, that's keywords permanent there, we'll discuss that in a minute. Severe arytenoid chondritis or chondroma, subepiglottic cyst, and cleft palate. So these are the basic things, and it's good they covered against these, but these are the basic things that buyers are covered against. Okay, laryngeal hemiplegia, you can see here. Left arytenoid here, not a great picture, but you can see the normal on your left and the abnormal is paralyzed. Example here again of the rostral displacement of the palatopharyngeal arch. Right here, this tissue here is abnormal. You can see how clean it looks up here. None of the tissue whatsoever. And actually, when these horses race, and this pulls down because of the negative pressures, this tissue pulls down and collapses over the airways where the horses can't breathe. No good treatment for that. We've tried to lase these things and pull the tissue back, but like I said, typically there's a cartilaginous defect within the bones of the larynx themselves that don't allow for these horses to run. Epiglottic entrapment, you can see on the right here, a nasty piece of tissue that's actually enclosed the entire epiglottis. This is the one where they use the little hook blade and pull down. They do well and some people have lased them too, but I think the laser can kind of get carried away and damage the epiglottis occasionally, so most people are using that old-fashioned, the hook blade. The problem here with this, especially on a pre-cell exam, one, it doesn't meet conditions, but two, you can't evaluate the epiglottis that we'll discuss in a little bit. You can't see the epiglottis, so you don't know how to grade it. But that has a pretty easy fix with a pretty good racing prognosis. Permanent displacement is another one of the conditions. Keywords permanent. I think I've had one horse in 30 years I've considered permanent, and its epiglottis was like non-existent. I never saw it. One of my good clients owned it. I never saw the epiglottis. If you can see the epiglottis, and this is where it comes in handy to do pre-sale scope, is if you can see an epiglottis just briefly, seconds, it's not permanently displaced. So it can be a very bad epiglottis that meets conditions. But permanent, you just don't have that many permanent displacements. Okay, chondritis, chondroma, another problem here. Can be no good cure. There it is. See this big left arytenoid, swollen, inflamed. You can't, they're very difficult to treat. Cartilage does not have blood supply, so you can't get antibiotics to it, sprays, etc. Just this horse is in trouble, especially racing, and sometimes even you'll have mares. You'll hear mares at some point all of a sudden sound obstructed, and they've had one of these chondromas, chondritises brew for years, and you have to do an arytenoidectomy on them. Okay, another condition is subepiglottic cyst. And you can see on the right the tissue here, and they can get just like huge, but those have a good surgical cure too. They do well. And then the last, but certainly not least, but this is the one you don't see a lot in adults or yearlings because typically they don't make it much past foaling, because these are the ones that you have your vet always run their hand in their mouth, or you'll see as a foal, you'll see milk dripping from their nostrils. Well, that's typical of a cleft palate. You do have a few horses that survive the aspiration of pneumonia that occurs secondarily to that, but it's not common to find older horses with clefts, but you do find them. And you see here, that is supposed to be soft palate filled in from there to there. That's epiglottis there. So you can see this horse is in trouble. And there's no good. I remember a long time ago we tried to repair a couple of these, Dr. Emerson did, and one of them actually held where the horse actually survived, the other one did not. Okay, so you have these conditions. So why in the world would anybody want to scope a yearling before they bid. Because the severe problems are covered, however, some things that are very undesirable are not. So that's the whole crux of the matter. You have very flaccid epiglottises. We'll show you some pictures of the very flaccid epiglottis that I'll show you pictures, and also the data, the racing data that goes along with the research I've done. Airways can change significantly in a short period of time. So by the time from farm scope to sale day, in the last year, I've had 2 airways, and I use a video scope so everyone can see them. It's nice to have. But I've had 2 airways that on like 17 days, 14 days before, they were nice little slight asymmetries, and then go to the sales 2 weeks later and be grade 3s and not meet conditions. So there's a huge difference, and I encourage my clients. I said, if you take a scope cert at the sale and you pay any substantial kind of money for the horse, you better scope it, because I've had changes in 2 weeks that are dramatic to the point where they don't meet conditions. So I encourage them to do so. There we go with the vet cert, the old A scope. Wide variety of opinion, and they change, like I said. And then, of course, another reason is pin hooking. I mean, these pin hookers they've got to have good airways, because they're reselling on the other end, the 2-year-old end, and they're more critical at the 2-year-old stage than they are at the yearling stage. And then, of course, I'll show you some problems that can be problematic that are not covered by conditions. That are starting to show up a little bit here lately, the last couple of years. The 2B airway, which I'll show you the numbers on those that they just don't do on average, and you have outliers, and we'll discuss outliers here in a minute, but typically the 2B airways, on the average, they run, but they don't do quite as well. And then the 3As, and 3A, BCs, we know they don't do good, and you'll have occasional 3A that will meet conditions, and you'll get stuck with it. We've got some examples of that. And so how do we base our opinion and information on? Well, years of research and experience, of course, to the point where we published, as a practice, I did about 3,000 scopes and published it a few years ago, and JAVMA presented at AAP, and came up with some real interesting data that had a lot to do with the way that I call airways. And it was nice to know, just to actually put kind of some numbers with what we're seeing clinically. Now, the one thing I have to say is during the study that all these scopes were mine, because we have to eliminate the inter-observer disagreement, because there'd be 5 vets that could call these different. So we tried to use all my 2Bs. I might call a 2B different than Dr. Burke calls a 2B, et cetera, et cetera. So, and then also reviewed, even though it's somewhat limited, there appears to be more, reviewed other research. So we used all those things to basically base our opinion upon. Okay, A throats, they're 1s and 2As. 1 is they both move symmetrically and equally. Maximal abduction is easily seen. 2As is where, and this is where it gets confusing, but there's slight asymmetry, which that's 70% of airways. They're not perfect, there's slight asymmetry, but maximal abduction is easily achieved and maintained. Key words there. Then you get to the 2B airways. Those are your B throats. That's where maximal abduction is more difficult. We've got some examples here in a minute. And usually if you see vets having to, and these exams take longer, 2-3 minutes many times. If you see vets that are having to nasal occlude and getting the yearling or horse to take a deep breath, that's typically what they're doing, is to holding off to get the retinoids to pull up. So you know that that's probably what, although there are some veterinarians that do that routinely, especially in 2-year-olds, just to make, to stress the airway. So you usually have to nasal occlude. Grade 3s, A, B, and C, A being the least worst, I guess, down to C being almost paralyzed but still has some movement. But cannot, the key here is they cannot achieve or maintain full abduction. And then, of course, grade 4s that you rarely see at the sale are paralyzed. No movement at all. Okay, here's, if I can get this to work, come out, there you are. There's an example of what I think is a pretty good airway. You can see both arytenoids are moving together. Maximum abduction is easily achieved and maintained. You can see a nice epiglottis here. The epiglottis has good thickness, texture, serrated edges. The cartilage is good. The vasculature is good. This airway is not displacing. Still has a pharyngitis like most of these yearlings do. I don't get too worried about it. But that's a pretty good airway. That would be basically a 1. Okay, let's look at the video first. Here's kind of my 2B, which I think some of my colleagues might call this almost a 3, but this is my 2B, and just watch this airway. This would be the more severe 2B. And we'll go over the numbers after you look at the video. Here's the left arytenoid right there. I'm holding the horse down. See his pharyngeal walls starting to collapse here, where he's starting to struggle breathing. And watch this arytenoid. There we go. That's a 2B, in my opinion, in my studies. Okay? Now, since 1s and 2As in the study were normal, there was no difference clinically and race with the numbers, statistically I should say, they were considered their normal group. So 1s and 2As were normal. When you get to the 2Bs, here's what we saw. From 68,000 to 52,000. So the earnings were still, the 2Bs still ran, they still earned, they were still productive horses. But they didn't quite run up to the same caliber as the 1s and 2As. The average per start was $9,200 versus 12,000, so it was less. And then in this particular study, and I know there's exceptions because there's outliers, but in this particular study, the best horse in the 2B group was a grade 3 winner out of 3,000 horses. And they, so they just didn't do quite as well. Whereas in the 1s and 2As, there were numerous classic winners and grade 1 winners, numerous in the study. Okay, let's see, next. Computer's locked up here for a second, I guess. Huh? Tech? Oh, kind of a helpless feeling. So the next one, if we get to it, well, I don't know if I've given this a couple times. I don't know if I can do it by memory. Plus the videos are bad. Oh, what'd you do? What? This thing. What button did you push? In case this doesn't work. The right arrow? Okay. All right. Grade 3s, these are bad ones here. Let's look at the video first. See already that the right arytenoid is moving more easily than the left, right there. And this one, if I recall, really, it's a bad 3, but it's probably a 2BC, because I don't think it ever meets conditions. And but it moves, so it wouldn't be a 4. It's not paralyzed. Now that's one. I've got an example of a 3 later that does meet conditions. So you got that, gets it up about 90%. So, okay, in comparison, here's your 1s and 2As, 68 and 12. Then talk about outliers. The total earnings in this study, in these grade 3s was 24,000, where the average per start was 5,300. But there was one horse that went overseas and raced, and at 2 won 366,000, well, like that one. So there's outliers. So that's why, and those would be your Dr. Knows, because everybody's going to fail that horse. But you have an outlier that just won 366,000. Of course, at 3, he was paralyzed, and he did a tieback, and he never started again. But you can see that some of these do make it, very rare. But then if you took this horse out of my numbers, it's like 0. I mean, it's terrible. So look what this one horse skewed my numbers so badly. But if you take him out, the numbers look terrible. So basically, grade 3s are bad. Okay. What arrow did you push? Huh?
He's on it.
Well, this is going to take longer than I thought. What was the next slide? What? Whatever. Okay, thank you. Okay. Let's talk about epiglottises just so everyone knows what those things are. It's this structure right here, right there, okay? It's the structure that rests upon the soft palate. It's a key structure. It helps ensure that the horse is a nose breather, not a mouth breather, because when the horse displaces, it becomes a mouth breather. That's when you hear the gurgling sound on the racetrack. You hear the noise, and the horse basically stops because they cannot breathe functionally out of their mouths. The basic function of the epiglottis, though, is to prevent food from going down the trachea. This better work. Huh. Okay, here's my epiglottis structure grades. 1 is 0 would be normal. You can see here, nice thickness, serrated edges, sitting on the soft palate, good vasculature. Here's a slight flaccid, not bad, maybe lacks serrated edges. It's got adequate length and width. Here's a pretty flaccid epiglottis, and interestingly enough, it's my grade 2 flaccid or a mild flaccid. These mild flaccids that are pretty flaccid, they ran the same as normals and slights. So I've become less critical of these epiglottises that look like this number 3 here, because they ran up the same, and I think they actually improve as the horse matures. Here's where you get into trouble. And these horses meet conditions, particularly if you get over here and you look at this one here. Look, this would be a pretty flat, it's a severe flaccid. These horses, and I'll go over the numbers in a minute, these horses didn't do well. So when they get like these 2 pictures, I get a little bit critical of those. Okay, when you compare epiglottises here, the one on the left was the average earnings were 66,000 and about 12,000 per start. And the one on the right, you can about cut that in half. So it does bother them. They don't run, they run, but they have about half the earnings and about half the earnings per start. So they just don't do as well. So this is one condition that meets conditions, but definitely affects the horse down the road. Okay, here, I've got a few examples now, and then we'll wrap this thing up, on some things that meet condition, but you've bought a horse. So here you can see here, this left, and in my opinion, this horse meets conditions, but you see the left arytenoid is a little swollen, and you see these areas right there and right there. He's had ulcers, he or she's had ulcers, and you wonder, well, is that chondritis? Is it yes, no, I don't know. Is it probably not? It's just an ulcer, but you can see this is affecting the horse's symmetry a little bit. The left arytenoid's not quite there. But this horse here could end up like the previous one that you saw that had the great big swollen left arytenoid. And a lot of clients, what they'll do is get some sort, and you guys hate this because you hate to give any kind of a warranty, but most buyers will say, hey, I want a 30-day, 45-day warranty on this to make these go away. Because I've had some of these where they get deep-seated, they get granulomatous lesions on them, you have to lase them, you spend the next 3 months treating these. So these are things that I think if you don't scope the horse and you buy it, that there's no recourse. You cannot return this horse. You've bought the horse. But that's one condition. Here's another one here. I can't remember which one it is. Okay, well, it's displaced. You can tell that. See, there's no epiglottis here, and all of a sudden, oh, there it is. You can see this horse, real flaccid epiglottis. You know, hurry and look at it while you can because it'll go away. See, it's gone. No, it's still there. You can see it's tugging and being pulled down there. It's displaced again. And that's just that horse's epiglottis. It is what it is. You would hope this one would improve. These typically don't. This would be an airway that I would be somewhat critical about. And then, let's see. This one's kind of a new thing we're having to address, and we're seeing more of this on the overground endoscopy, the dynamic endoscopy, where we're doing it on racehorses, on the racetrack or on the treadmill. Watch this here. As we get in, you can see the horse is displaced, but that's not the thing we're looking at. Watch this here up at the top of the arytenoids where these things fit together. This corniculate process is right up here in this area. And watch as I hold this horse off. What happens here? You can see that's his trachea right there. Look at this corniculate process, how it dips down when he takes a deep inspiration. See how it shifts down? And they don't overlap. We've had a lot of these horses on the treadmill or the dynamic endoscopy that actually that thing continues to collapse. There's no treatment for these. They continue to collapse. This horse would meet conditions, by the way. It would be sold horse. But that corniculate process continues to collapse down into the airway, and they basically have exercise intolerance and they can't breathe. And that one's not covered by the conditions you would buy a horse. This is an interesting here. Meets condition. This was an A scope with a cert, an A scope that went through that my pinhooking client bought and sold for a fair bit of money. You guys tell me what you'd call this. I won't even say a word. And that's where I'm loving this. I'm scoping out on the farms. I don't even have to call them anymore. You guys do. So this was an A scope. Bought the pinhook last year. Has anybody seen that abduct yet? I haven't. Maximally abduct. It's moving. But this horse, on a subsequent exam, this horse was thought to meet conditions, so it never went to arbitration or anything. So the guy took the horse. But it will be interesting to see this spring what this looks like. I'm sure it probably won't look real pretty. But you can see I've worked a long time here, and I've yet to see this horse meet conditions of sale, but it does. And this would be another reason to scope a horse before you buy it. There, displaced. So this horse it's getting there, 90%, maybe 80. So it's thought that this horse met conditions, but still undesirable, especially if you pay a lot of money trying to resell this horse. Good luck with that. Okay, finally, just to give you an idea, the horses that are raced versus unraced, you can see the grade 1s, 2As, and 2Bs. They all race about the same percentages. I mean, unraced and raced about the same percentages. But then you get down to the grade 3s, about 50% of them are unraced. So, I mean, that just goes to prove that further that the grade 3s are bad. But it goes to prove further that the 2Bs run. They run the same as 1 and 2As. They just don't run up to the same caliber. So that basically, I think, is the last slide. Later, I don't know what time we quit, but we might have a little time for questions afterwards, but that's the end of my discussion. Thank you.
Is going to talk on the radiographs, findings, and significance. Dr. Spike Pierce received her DVM from Michigan State University and College of Veterinary Medicine in 1993. For the next 2 years, she completed a internship at Rood and Riddle, and then for 3 years, she was assistant to Dr. Larry Bramlage, working with him outside of surgery in lameness and diagnostic imaging. In 1998, she joined the ambulatory department of Rood and Riddle and focuses on diagnostic imaging, lameness, and public sales of young thoroughbreds. She has spearheaded research in yearling orthopedic abnormalities and has spoken nationally and internationally on radiographic changes. Dr. Spike Pierce is a past president of the Kentucky Association of Equine Practitioners and the Kentucky Veterinary Medical Association. She currently serves on the board of the AAEP Welfare and Public Policy Advisory Council and the KVMA Legislative Committee. Dr. Spike Pierce.
Thank you. Can everybody hear okay? Is there a way to turn down the lights? Anybody know? As I fear a little bit that it's going to be tough to read some of these radiographs on here, because I'm going to show you a lot of radiographs. And basically what I'm going to talk to you guys about is yearling radiographs. What do we see at the sale? What are our findings? And what is the significance of them? But more importantly, we're looking at front fetlocks, hind fetlocks, carpus or knee, tarsus or hock, and the stifle. And I really want to get the point across, look how small these areas are, and we really need to be evaluating the whole horse. It's not just about the radiographs, it's not just about the scope, it's about putting the whole picture together and setting a value on these animals. They may have something that might be a little bit undesirable, but is it still possible that you could purchase that for maybe a discounted price? But again, there's so many things that we're looking at, and the radiographs are only a part of this picture. So back in the balking ring, you have these radiographic reports. Are they really radiographic reports, or is it a radiographic interpretation? A radiographic report is basically saying, this is what's on this horse. This is the findings that I see. An interpretation is telling you, what does this really mean? You know, what does it mean to you as a buyer or as a seller? So I think those are, we don't have a specific one. Most of us will have our radiographic report and then tag comments on after that. There's a lot of different terminology. You can have NSA, no significant abnormalities, no significant lesions, no abnormalities found, and the list goes on and on. We might say something and make a diagnosis and then say, I use the word okay, not very scientific, but I think it's okay. So I want to let somebody know that I think this is okay. Some people will say insignificant. Some people will say good prognosis. What does that mean? Good prognosis. Is it good prognosis with surgery? Or is it a good prognosis for racing? I think those are some things we always try to not write any more than we have to on reports, because it's not in fashion to have much wording on the report. So we try to be as brief as we can. And then there's also this one, not clinically significant. Well, what does that mean? Not clinically significant to me means it doesn't have a big joint right now. You can have a hock that has an OCD that's not clinical, meaning the joint is nice and tight. Is it always going to be that way? So not clinically significant to me is more of a picture in time, but you still need to look what could happen later on. And this is an interesting paper. It's about to come out in the Equine Vet Journal. It's not out there yet, but it has been accepted, so I know within the next year it's going to be coming out. But this was done out of Australia, and what they did is they looked at the assessment of intra and inter-observer agreement on reporting orthopedic findings on sales radiographs. And these are all radiology specialists, so they're boarded radiologists. And there were 4 different people that were doing this. And what was interesting is they were very they were very much in agreement on the absence of findings. So if a horse was clean, it was clean. But they were also in good agreement when you got to larger lesions. Say there was an OCD. So that was specific, they could say that. But when you got to these things that aren't always straightforward, like sesamoiditis, spurring, little enthesiophytes, it was a very, there was actually a very poor correlation. And these are all boarded radiologists. And there's no consigner, seller, buyer discrepancies. They're reading these just as radiologists. So there really truly is a very subjective part of interpreting radiographs when we're looking at them from the sale standpoint. But I think that's it's an interesting paper, and it just shows that there is some subjectivity to this, and everybody reads them a little bit different. So the most comprehensive study that we have on these is a study that was done out of Colorado. Kane did this. He's on staff there, but it's a two-part study. They looked at radiographic changes in thoroughbred yearlings, and then they also looked at what these changes do as far as performance. So this is part two, where they looked at performance, and the study as a whole, there's over 1,000 horses in this study. So it's a really good study. A few things that it didn't include, it didn't look at medial femoral condyles and the stifles, and it also did not look at pasterns. So, you know, what we're seeing today on reports, those are two things that you would be seeing that's not in this study. But there were only 4 things that really affected horses as far as starting that they could come up with in this number of horses. The first one was moderate to extreme supracondylar lysis. I'll show you what that is and explain it a little bit more later, but they had decreased start. Enthesiophytes formation on proximal sesamoid bones. This is in the hind limb. And enthesiophytes where it's basically a spur, but it's where a ligament attaches and it somewhat pulls on it. They had decreased starts. Proximal dorsal fragmentation of hind fetlocks had decreased starts, which that's basically a P1 chip in a hind ankle. And at the time the study was done, we were all very surprised by that. But when you think about it, I think a lot of people would say, oh, it's in the hind ankle. We don't need to take it out. It's a little chip, not a problem. Well, I think this shows us that they probably do need to come out because it didn't affect them if they had chips in the front ankles, but it did behind, which tells me the ones in the fronts were probably removed. And then lastly, the other thing that affected performance was dorsal medial intercarpal joint disease. That's the lower inside portion of the knee. And that's a common concern for most people, so that wasn't a surprise at all. So I'll go through, and I'm just going to go through radiographs and let you see what these lesions are, and then tell you what research there is out on there on these particular lesions and how we know if they're okay or they're not okay. So first thing, this is normal on the left, and you'll see a dorsal P1 chip. Let me just show you. This is your fetlock joint. If I can get there it is. So this is your cannon bone. These are your sesamoids. They're superimposed on each other because this is a side-to-side view. And this is the pastern bone, or the long pastern bone. And right up there is your P1 chip. So Dr. Colon, when he was with us, did a study where he looked at these in horses that had surgery. There were 461 horses. Of these 461, about 140-some, 45 or 46, had not started a race. What was really great about this study is 89% of these horses went back to racing after surgery. So you even have some horses that didn't even start races. So very good percentage, very good success rate. Next, another thing in the fetlock again, here's your sesamoid bone. This is your sesamoid, cannon bone, P1, and this is your fetlock joint or your ankle. So the slide on the right, this is a chip in the back of the joint. These are usually in the hind ankles, and these do very well with removal. Some horses will get by with them, and you wouldn't have to remove them. But the problem is we can't determine at the time of sale whether or not this particular chip is going to bother a horse when they're racing. So usually most people are going to want to remove them and take out the possibility that it's going to be an issue. Now next is, those ones are more traumatic. This is also a traumatic lesion. Maybe they do this out in the field, just hyperextending. But this is a fetlock, a P1 eminence fracture, which is just a fracture that takes off more of P1. It's not just a little chip. And this was non-articular, so it doesn't go into the joint. The joint's up here. Many of these are very scary from a purchase standpoint, and people don't want to buy them, but the majority of them heal. Not all of them heal with a bony union. So some of them might look like this next year. And then it's very difficult to sell as well. So I can see from a standpoint of pin hooking, a lot of people don't like to buy these because they may not heal. The vast majority do, and the racing prognosis is very good. Sorry, this is what I'm talking about, the eminence fracture. Next, we have an apical sesamoid fracture, and you can see where it is up here. And this is at the apex. That's why they're called apical, so they're at the top of the sesamoids. And we've actually looked back on a lot of these. Most of these are hind ankles in the thoroughbreds. Dr. Schnabel, when she was with us, she looked at these and 151 cases, and they were less than 2 years of age, so these are yearlings. And what she found was that they actually do very well with removal. In the hind legs, they were totally normal. In the front, they had decreased performance. When they divided them up, the ones on the outside, or the lateral sesamoid fractures, did fine. It was the medial, or your inside front legs, that had a poor prognosis. And actually only 44% of those raced with the medial apical sesamoid fractures. So with that, we were wondering, well, is it just they were big, or why does it affect them so much more? So Lacey Cam looked at the size and geometry of the apical sesamoid fractures, and the bottom line was it didn't matter. I mean, you could have a large fracture, as long as you took no more than 1/3 of the sesamoid border, the abaxial border, they did very well. So front medial sesamoids are a concern and something you would have to figure in to purchase. This is a difficult one. I think this is the most commonly missed radiographic finding. And the reason being, it's never out on its own. This is an abaxial sesamoid fracture. If you look at the sesamoid itself, this is the abaxial surface. This is where your suspensory attaches, like a big thumb right there. And then this portion right here, this kind of line where it goes from light to darker, that's the articular abaxial portion. You can see the fragment over here. The only way to really see that clearly is to take a skyline view and set it off by itself. So they're difficult to diagnose. From a sale perspective, I feel of them a lot like I do apicals. I mean, the suspensory is involved on these. You don't know unless you scan them how much of the suspensory is involved. And obviously that's the big issue is, how much can we live without? So I'm more critical for front medials, kind of extrapolate it from the apical sesamoid fractures, but don't really know that without doing the research, which we don't have yet on that. So non-articular base sesamoid fractures. So we've talked about the apex, the abaxial, now we're to the bottom of the sesamoid. Sesamoids are really critical, and you'll see so many more things on fetlocks than any other joint. So this is a base sesamoid fracture. This is not articular. So it doesn't communicate with the joint. There's actually ligaments at the base of the sesamoid that are attached there. And Dr. Wellman, when she was with us, looked at this, and she looked at horses that were going to a sale. And so they were sales surveys. So I think we probably lost a few numbers in there because she only had 37 in the study. But it was interesting to find out that these horses raced just as much, had the same number of starts, they just made less money. So they were lesser caliber horses compared to their maternal siblings. In all of our studies, we're comparing them to maternal siblings for the most part. So this is a base sesamoid. The problem with these is it's not like a chip of these other fractures that you can just take out if they cause a problem. These ones are attached to a ligament. Here's another one, the fretlock, a proximal sagittal ridge OCD. This thinner area is the sagittal ridge, and you can see this little piece at the top here. These do very well. They look normal after removal and perform well. Fetlock mid-sagittal ridge OCD, or lucency. Let me talk about lucency first. You can see the ones normal on the left, and then where I have that circle, you can just see how it's a little bit more lucent at the bottom of that ridge. And these are usually improve with maturity. And most people are less critical of these unless they're very inflamed or have fragments. But the reason being is that they usually mature and go away. Now this is a more significant one. This is a front to back view on the left. Looking at this ankle, this is the mid-sagittal ridge. And here's a more severe one where I would actually call this an OCD because you have the lucency and then it looks like you have a flap or an actual fragment right here. So this one would be more concerning. We don't usually remove these because one, they would look worse after you remove them because you would have a big hole, and two, because most of them heal. So this horse actually did go on and heal this mid-sagittal ridge, but there's a lot of changes that can go on there, a lot of roughening, but the majority of them are okay. So next we have a fetlock lucency or cyst. You can see the picture on the right where you have that lucent area here right at the condyle. Now this could be, I know there's always a lot of discrepancies on reports. Is it a lucency or is it a cyst? Which one is it? You can call it either. This is a subchondral lucency, meaning subchondral meaning the cartilage, so it's below or above the bone, or it's in the bone. Oh shoot, didn't mean to do that. but above the cartilage. So that's the subchondral lucency, or you could be fine calling this a cyst. These are lesions that, if they go bad, they go real bad. So you have to be cautious in what you would recommend. This particular one, there's a lot of white around that lucency, which tells me the bone's inflamed, so there's sclerosis. And I would be much more concerned about this than one that didn't have any change around it as far as the bone. And it also depends on where it's located. Some of these may be more in the front of the joint, which is probably fine. If they're in the back of the joint where the condyle takes up so much stress, those ones are far more concerning. So this is, again, something that would significantly affect your sale price. This one in particular would. There's some that there's a pretty significant gray area. You know, we don't know. And if you look at Kane's study, this didn't make any difference. So it tells you there's variations of this type of lesion. And you can call it either a lucency or a cyst. Sesamoiditis. Now this is the most common and confusing radiographic finding that there is. And this is the first paper I did on yearlings, and is why. Because this is a normal sesamoid on your left. This one doesn't really, maybe a small canal here, which is normal. Vascular canals are normal. That's how the blood vessels get into the sesamoid. But when they get inflamed, the vascular canals get large. And the definition of an enlarged vascular canal, at least my definition, is they had to be more than 2 millimeters wide, they had to be going out, and they had to have this edge at the back. So it almost is like a club. And so you see there's 2 enlarged canals in this particular horse. Now the study that I did, when we looked at this, horses that had 1 or 2 enlarged canals, it affected their performance at 2, but they were normal at 3. Now if you had 3 or more, so getting more significant sesamoiditis, they were affected both at 2 and 3. It's not that they didn't race, but they had decreased performance. So that was the first way that I could really judge, but there's so much variation in sesamoiditis. And let me just show you, I mean, these are 2 other ones that, you know, all of these would probably be considered moderate sesamoiditis. This horse on the left has, I'd probably call it 3 enlarged canals. The one on the right, these canals are actually linear. And that doesn't bother me, but you have the misshape into the sesamoid, the little pull here where the suspensory attaches. And more concerning is this lucency kind of down here. These ones usually are going to scan poorly. They usually have tears in their branch or a lot of inflammation. A new study that's coming out, it's been accepted to Equine Veterinary Journal, but it hasn't been out yet, is Jonathan McClellan looked at this, which is great because we need some follow-up from yearlings to 2-year-olds. And he has looked at the insertional desmopathy, which is where the suspensory inserts on that sesamoid bone. And what he has found is that horses that had the enlarged canals, they were more likely to have significant tears in their branches. Now, if they just had a mild tear, they maybe had decreased performance at 2, but went on and did fine at 3. But if they had a more significant tear, it affected them at both 2 and 3. So very similar to what the canals were on my sesamoid study. And then here's another kind of sesamoiditis. If you look at the sesamoid on the left, which is normal, and then the sesamoid on the right, you see this big defect out of the back. And a lot of these get inflamed and lucent and look very ugly, bottom line. But what's interesting is in my paper, they weren't significant. And I think the reason why is a lot of these, we say they're trauma along the back or palmar sesamoid trauma, is that the suspensory doesn't attach there. It attaches along the side. So the vast majority of these scan fine. Now this is something I would like to take just this particular lesion and look at a large number. I only had 30-some in my study, but it did not make a difference. It didn't affect any performance in the study that I did, but obviously we need more numbers. Now this is, you heard me talk about supracondylar lysis. Whenever we put that on a report, everyone's like, what is this? Never heard of this, sounds very unusual. But what supracondylar lysis is this narrowing of the cannon bone right above, let me get this, right above the fetlock joint. So here's your joint, and see how this cannon bone gets really narrow right in here, where you have this other one is very square looking. Well, you can see that doesn't look like a very strong joint. I mean, just looking at the radiographs, I think you guys can deduce that that might be a little bit of a problem. Well, it was significant in the study. One thing, I don't usually see this without some other significant radiographic change. It's just something I don't usually see on its own. But I'm looking at it more because after the study came out, we were all like, ooh, I need to be looking at that more, or mentioning it more. So I think we do look at it more. Maybe we'll find out. I did ask Kane when he did the study, did you see other changes with it? And he said no. So that's an interesting one, but it certainly affects them. Next, let's talk about the carpus or the knee. This is the upper joint. Let me get this is your upper joint of your knee. This is your lower joint. And this bottom joint doesn't move. So it's just these two that are moving. And here is some spurring in the upper joint. So your proximal intermediate and distal lateral radius. And a study that we did with Jen Higgins when she was with me is looking at the spurring in the upper joint, but we were looking at it with accessory carpal bone fragments. So the little fragments, this is the accessory carpal bone in the back of the knee. And that basically is just a prop in the back of the knee. It doesn't have a huge function or pathology that we see as you do in the front of the knee. But when we have those, oftentimes the joint gets very inflamed and develops these spurs. And you try to sell those, it's almost impossible. I mean, I'm sure several people in the audience have had these, and they have significant spurring in the upper joint, and they're very difficult to sell. So we wanted to look back at them, and we did. And we looked back at them without spurring, mild spurring, and moderate spurring. The ones that did great were the moderate spurring. So I think it tells us a lot that, first of all, the upper joint's very forgiving. And two, why does it have those spurs? I think anytime we have changes in knees, we need to go back and look at conformation. We need to see how they walk or track through their knees. Are they back at the knee? Things like that give you an indication is the reason why they have these changes. To me, the indication was they had accessory carpal bone fragments, and that didn't seem to bother them, and this particular horse. Other things, so the carpus will go into the lower joint, and so this is upper joint again. This is a different view. Here's the lower joint. This one actually has an accessory carpal bone fragment. But here's the lower joint, and over here on the right, we have a large spur on the distal radial carpal bone. This is one that, with Kane's study, showed that this was significant as well in decreased performance in starts. And this is one thing I have to say, and probably I would think most veterinarians would agree with me. When you talk to a new client and you are trying to figure out what's their level of tolerance, what is your risk level here? What can you tolerate? The number one thing I always get is I cannot tolerate lower knee problem, anything in the lower joint of the knee. Well, this would be it. This would be one of them. The lower you get in the knee, the more inside of the leg, the worse the prognosis is compared to up in the upper joint and the outside. And rightfully so. When these ones have problems, they usually recur. And the reason they recurred is because they were having problems with their knees to begin with. Either it's conformational or they have a reason that they're having problems there. Next is the hock. Here's a typical hock OCD. This is distal intermediate ridge, very common. There was a study years ago at Ohio State that said these are basically normal once they're removed. They do very well. Hock spurs. Here's a spur. This is the hock, and here's the lower hock joints are right here. This is your cannon bone, or proximal MT3, and you'll hear us say spur proximal MT3 a lot. That's what that particular lesion is. I think everyone is very forgiving of these. They're very common, for one, and Kane had this in his study, and it wasn't significant as well, but I think most horses respond if they do need injections or whatnot. Hock compression. This is something that we'll see when horses are either premature, maybe they're very sickle hocked foals, maybe they're just mature, and they go out and they exercise and they traumatize these joints, and then these joints are irregular in shape. Well, these irregular joints wear faster in training. So they might make it to the races, but they don't last very long. And I will know more about that because we're looking at those this year. Stifle OCD. This is a paper I did where we looked at 518 thoroughbreds that had surgery, either as a weanling or as a yearling, on stifle OCDs. You can see this. This is the patella right here, or your kneecap. This is the, where this lesion is, the lateral trochlear ridge. That's the most common area. This is very small, and that's what we found out in the study, was that if they're small, not a big deal. Actually, small is relative. Under 4 centimeters, which is a pretty good size OCD, these horses did very well. You get over 4 centimeters, and they did not do as well. Had decreased performance in many of our performance categories. However, their earnings per start in the most severe category was the same when you compare them to their maternal siblings, which makes you think that there are some of these horses that do make it and they do very well, even of the large OCDs. Medial femoral condyle cysts. Emily Sandler looked at this. This is something that wasn't in Kane's study, but she looked at this when she was with us and looked at the size of the cysts and say, hey, does this make a difference? These were all horses that were lame and had surgery. And what they found is if the opening of the cyst or the amount of joint surface is less than 1.5 centimeters, about 70% of those horses raced. If it was more than 1.5 centimeters, it was only 50-50 to race. So this is something that, depending on the size, it can be pretty significant. As well, cysts aren't like chips where you can just take them out and be done with them. Cysts are, when you remove the opening of the cysts, the bone has to completely remodel. So it might take you 6 months after surgery to get where you want to be. Another thing on condyles that we see is this medial femoral condyle lucency. You see the normal one on the left, and then this lucent area and sclerosis in that yellow circle. You know, is that going to develop a cyst? That's one thing we always wonder. Is it going to turn into one? Is it going to go away? Don't really know that. Jeremy Whitman looked at these, and as well as cysts. And these were horses that were sound. They went through a sale, and what they found is they had decreased median prices at the sale. So they sold poorly, but the bottom line was that they did the same as, they compared them to the horse in front of them in the catalog. And there was no difference in performance. But I think a big difference in the two studies is, one, we compared to maternal siblings, and two, these horses were not lame. So who knows? Maybe those ones do okay. I mean, we need to do more research there and kind of find out where we are. Pastern cyst. This is one that I did with Dr. Vargas when she was here, and the reason that we looked at this, so you have the fetlock up above and then the pastern. The reason that we looked at this is because in the November sale, it seemed like I saw several really like grade 1 winners that had pastern cysts, and they're discounted so much from a yearling perspective. I really wanted to look into it, and what we found, and we had good numbers, we had about 180 of these, is that if you have pastern cysts or lucencies on your distal P1, so down here on the lateral or medial side, or on the top of P2, on the lateral or medial side, they raced normal. So, I mean, granted, there's going to be a few exceptions, just like Scott was saying, as far as outliers, but the bottom line is these do very well, and it makes me more comfortable, you know, when you have somebody wanting to pay a lot of money for a yearling, that, hey, I can say this is fine. And then another thing is just, this is a pastern avulsion. Just because Kane's study didn't include pasterns, this is something that is very significant. That's a very important attachment, superficial distal sesamoidean ligament, and that's the primary support for the back of the pastern and the fetlock. So again, I mean, these are things that, you know, right now it has a fibrous union, not a bony union. Can it tolerate race training? And we'll need to look further at that. So that is it. Is there any questions? Yes?
For both of you, thank you. I think this audience is particularly interested in the approach to the whole horse. And I'm wondering, what's your opinion of increased standardization for both of you as far as reporting this information to a lay audience?
I think the question was, what do we think about increased standardization for relaying this information to a lay audience? I think it's very important, but there are some things we can't standardize, like the sesamoiditis. There's just a variation in opinion because it is very subjective even when you have radiologists looking at them. There's such a variation in definitions, and I think we're better than we have been, but I think we have still a long ways to go in trying to improve that and trying to explain things. And part of it, when you're doing pre-purchase, and Scott's always told me this, is your cup half full or your cup half empty? I mean, you're always trying to, you know, explain it with your cup half full, saying, hey, you know, this is where we are, this isn't that bad. I mean, maybe you get it for a little bit less than what you had hoped, that type of thing. What do you think or say?
As far as airways go?
Well, yeah.
We did run longer than we thought. Anyway, yeah, well, just wrap it up here. I think you're right. We'd like to standardize. I think that's one reason to go the 1s, 2As, 2Bs route, because it actually it gives a true meaning of functionality of the airway. Standardizing that's problematic because it's no different than you looking at a horse and Meg looking at a horse. You're going to disagree on a lot of different things, and how you standardize a 2A or a 1 or whatever, and whether the horse is displacing all this dynamic change. It's very difficult to do because the opinions, as you well know, and everyone in here knows, the opinions just vary widely, so it's very difficult to standardize that. And it's probably one of the most important examinations that occurs, so I just think it's pretty problematic to standardize it.
Thank you very much. Thank you.